Okay. And I'll bring back in session the meeting of the Watsonville Community Hospital Board of Directors for Wednesday, January 28th. We're going to roll right into public comments on matters not on tonight's agenda. And I'll go online first. Anyone wishing to speak on any items not on tonight's hospital board agenda? And seeing no raised hands, I'll go out to the public. Anyone wishing to speak on any items not on tonight's agenda? Okay, close down the public comment and I'll bring it back to comments from our board members. Any comments from our board before we move on to the consent agenda?
I don't want to take too much time because I know we already went outside for the vigil, but what a wonderful vigil for such a difficult time. And I hope we can explore supporting the county and with our discussion on what our hospitals doing about making sure everybody is safe. So I'm really pleased with the turnout. It's a really hard time, so.
Thank you. Any other comments from our board before we get started?
Echo Director's comment and thank our nurses who organized the vigil. It's been hard these last couple of days to process all of this. I think having that moment was reflective of who we are as a community, and I feel a lot of appreciation, the solidarity that we have and come together in moments like this, and trust that we'll be able to navigate through this. And just so frustrated for what we've been dealing with as a community in a hospital, and now what individually we're experiencing. Just appreciate the moment of reflection.
Any other comments from our board members? Okay, I'll move us on to our consent calendar. We have, I believe, 3 items tonight. Item number 1 is our minutes approval for meetings on December 17th and January 14th. And number 2 is a correspondence that the board received between December 15th and January 20th. Then item number 3 is policies / policy summary approval for January 2026. I believe for item number 3, we also received supplemental attachments for tonight's agenda. Should be in front of all the board members. Any questions for staff about either of these 3 items, please, Joe?
Steve, on the correspondence on your letter, just to clarify, take us from seismic 4 to 5 is all we need is these, they're a simple project. The water storage? The water storage, yeah. That's it. Yep. Thank you. Yep.
Cool. Any other questions before I open up for public comment on either of these 3 items? Okay, then I will open up for public comment. I'll go online first. Anyone wishing to speak on the consent agenda? Seeing no raised hands, I'll go out to the public. Anyone wishing to speak on these items? Seeing no raised hands, I'll bring it back to the board for any final comments and an appropriate motion.
Move approval of consent.
Thank you. Can I get a second?
Second.
Thank you. Directors Pimentel and Gallagher, I'll take roll on this item. Director Friel?
Yes.
Director Pimentel?
Yes.
Director Gallagher?
Yes.
And Mr. Attorney?
Yes. Okay, we'll move on to our discussion items. And first is the Medical Executive Committee's report approval for January 2026. This was this is a report that received in closed session from our Chief of Staff for the Medical Executive Committee, for the Chair for the Medical Executive Committee, Dr. O'Grady. Any questions about this or about this report for staff before I open up for public comment? Okay, seeing none, I'll open up for public comment. I'll go first online. Anyone wishing to speak on item number 4? Okay, seeing no raised hands. Anyone with us in person wishing to speak on this item? No raised hands, I'll bring it back to the board for final comments and an appropriate motion.
I move to accept or to pass it.
Can I get a second? A second. Thank you.
Thank you, Directors Pimentel and Pimentel, sorry, I'll take roll on this item. Director Friel,
Yes.
Director Gallagher,
Yeah.
Director Pimentel.
Yes.
Director-
Yes. Okay, that'll bring us to item number 5, our leadership report from our CEO, Stephen Green.
Great, thank you, Chair Nunez. I'm gonna let Chief Nurse Trina kick this off.
One moment. Share.
So I just wanted to express our sincere condolences to Mr. Petty's family, his friends, and all of our healthcare colleagues across the nation. Very tragic incident. So just wanted to acknowledge that. Leadership had a response. We sent an email out to all staff addressing the issue. Attached to the email was our flyer that we created in terms of how to respond if ICE shows up to our facility. And then we also attached our EAP flyer to that. Everybody, responds to things differently. We know that this really hit very close to home for many of us, being that Mr. Preddy was an active ICU nurse. And so, we just want to make sure that we have the information there to support staff should they need it. Also, we did a high-level overview education to our nursing directors yesterday. And a lot of good conversation took place. And in that, one of the recommendations that we discussed was creating an overhead code for if ICE arrives to our facilities. So we're in the process of doing that. We also, Steve, thank you, Steve, has reached out to the Community Action Board and received more red cards. So we make sure that we have enough to give to all of our patients in the hospital. And we also assigned education to all staff through our HealthStream platform that is required. So all staff will be receiving education on how to protect their patients, how to interact with ICE should they show up to our facility. And that's all 600 employees here. That's not just nursing. So we want to make sure everybody has the tools. The workplace violence, there's been a little bit of an uptick that we've seen recently. Most notable is a recent attempted assault, stabbing on one of our ER nurses. Unfortunately, executive leadership did not find out about the incident until a couple days later, but our quality department went into action very quickly as soon as we were made aware. We've had several meetings. Several of them have been multidisciplinary, including HR, employee health, Watsonville PD, the district attorney's office, our facilities. We've identified some safety gaps and some areas of opportunity in terms of our response and how we can, disseminate information a little bit faster and make sure all the key stakeholders are aware. We are scheduling a meeting with Watsonville PD to have a very robust partnership with them. We also have developed some process changes. One of them was the communication improvement on our BOLO alerts. Who's responsible? One of the things I learned, I think many of us learned, where there are different levels of the BOLO alerts depending on the safety threat. And so, another thing, so our response to that has been evaluated and, we are improving that. Also, our quality and risk department, along with the ED director, are working on creating an escalation pathway. So to make sure, again, that all the people that need to know about these incidences are alerted right away. We also, Beta is our insurance carrier, and they're coming out and completing a workplace violence risk assessment in February. So we should have some good takeaways from that as well. We really want to make sure that we're supporting staff and that every staff member feels safe when they come. CCU update, this is our most current January census as of yesterday. So you can see on the left there, it shows how many patients from 0 to 4 patients and throughout the days of January. We had a little bit of a lull there, but then it looks like it picked up. We are continuing our ongoing recruitment. So we recently had 1 full-time and 2 per diem, variable per diem nurses attend new hire orientation. They both have been oriented to the unit. So that is good. We have reached a collaborative agreement with the ICU nurses to rebalance the schedule. Originally, that was only through February 7th. We met with them on Monday and we approved a new schedule that takes us through March 7th. So we do have ongoing recruitment. The director has 4 interviews scheduled, 1 on Friday. So we're very hopeful that we will be able to have those new people in new hospital orientation and on the night shift. So I just really would like to say thank you to the ICU nurses for working with us to problem solve. And for those that have gone from day shift to night shift to help cover, we definitely recognize that is a major disruption to people's lives. So I just want to say thank you. Surgical services update. We did have a recent resignation of our surgical services director. Susan Casperson is our ICU cath lab director, and she's now interim helping take over for surgical services. Ongoing recruitment is happening. We did have a multidisciplinary interview panel last week. And we have another candidate that we are interviewing tomorrow. And then there's another interview candidate that will be interviewed possibly next week. Not sure what day exactly. So we do have some good candidates that we're interviewing. Regulatory updates, Joint Commission, we are in the queue for them to come back and redo a site survey here. And for CDPH, I'm very happy to announce that February 3rd, they will be here to do our site survey. So fingers crossed. We've submitted all of the documents they needed, including our HCI pad, all the qualifications for that. And so they've reviewed all that paperwork. Hopefully it's a quick walkthrough and we will get their seal of approval.
Yes.
That's it.
Okay. We want to pause here for any questions for Trina before we move on to the CEO report.
Thank you for all this work.
Can you remind me what the Joint Commission is coming back to look at, or?
So when they came for their last survey, they informed us they'd be coming back just because of some of the areas of opportunity they found. And so it's our turn to now show them what we've done and how we've improved.
Great. Thank you.
You're welcome.
And for the walkthrough of the MRI, that's the MRI trailer, is it?
Correct.
And any updates with the actual MRI replacement project? Still in the middle of construction for?
Still in construction. So the MRI is in non-OSHPD space, so it's under the jurisdiction of the city of Watsonville. And so the construction drawings were submitted to the city a while back. Just this week, they got back to the construction team with their comments. And so now there's a hopefully brief back and forth between the construction team and the city to finalize those. So that process was, did go longer than we would have hoped with the city, to get to this point. And so we are, we're looking at arrival date of the MRI, which is not an opening date, but an arrival date of the machine itself in May. CT scanners should be a month or two earlier than that. Okay. As well as the fluoro room. And the arrival usually that takes a couple weeks to a month to get it all installed, get everything buttoned up around it. You gotta get final approval. Right. Yeah.
Thank you. Any other questions for Trina before I get to Steve?
Go ahead, Steve. I'll keep going. You've heard their names before, but wanted to again welcome now that they are both fully here. Dr. Rob Allen started on December 1st as our new general surgeon in Coastal Healthcare, and Dr. Jennifer Etchison, our new orthopedic surgeon, started on January 1st of this year. And so they are both hitting the ground running and building their practices. We are working on referral packets for them, for us to get out to all the local primary care providers to know who's here now and what they do and what they can refer to us and to our new surgeons. So we're very excited to have them on board. Number of sort of legislative financial updates. So the fee program, so the hospital fee program or the QAF program, the QAF program, right? We're in program 8, program 9, really should have been approved almost a year ago, never has been. Had it been approved by CMS at the level that the state had wanted it to be, it would have been a nice increase for us, helped us offset a lot of our losses. The CMS response back to California has essentially been, you should probably just ask for program 8 level dollars and not program 9 level dollars. And they've given the state a 60-day extension to respond. The state does plan to respond quicker than that. But we are still looking at, even with how conservatively we thought we were budgeting the QAF dollars for 2026, we're still looking at it. It's going down all the way to program $8. We're still looking at probably an additional $3.3 million hit compared to what we had budgeted. So if you think about our $5 to $7 million negative budget, it's now adding 3.3 to that. Again, these are still estimates because we still don't know. We still don't know timing, but that's the latest information that we have, latest estimates that we have based on that. The 340B program, which Jennifer's in our audience, thank you so much for all of your work on this. We've already been able to save quite a bit of money this year through buying drugs through the 340B program. There has been a push by the current administration to move it to a rebate model, which would really be a boon for the pharmaceutical industry because it would make it a lot harder for hospitals and providers to get those discounted prices, because rather than just getting the discounted prices, you actually have to buy them at the full price and then submit for a rebate. And obviously that is not good would not be good for providers. So California Hospital Association is pushing really hard against this. It has been blocked by federal courts up until this point. We'll continue to talk with CHA and hope that that continues, but that's where we're at with that at this point. We're still in our 340B program as it has been originally designed for now. And then the last one is the Rural Health Transformation Program. So I think I mentioned before that California received $233 million for the first year. That was less than Texas and Alaska and the same amount as Montana. So for whatever that's worth, based on population size and things. And then after I submitted these slides to Rosie, and actually just this afternoon, CHA sent out another letter. So I'll read some of the excerpts from it because it's specific to this program. Their first bold bullet point is this process will be slow. So that's great. And then it says hospitals are not guaranteed to receive funds. The eligibility for these funds is far broader than hospitals and health systems. The application process will be competitive, but hospitals are likely well positioned to apply for funding in various categories. Ultimately, the state will decide how to allocate funding. By January 30th, HCI must submit a revised project budget based on the award amount to CMS for final approval. We likely won't have any visibility into that. CMS then requires a 30 to 45 day window to approve the state's budget, during which time no funds may be distributed. So March at the earliest, requests for proposals and other related program activity may begin after CMS program approval is received. So first year funds, the state must allocate them by no later than September 30th. And then they have to be shown to have been spent by September 30th of 2027. So that was the latest that we received just this afternoon. So not continuing to work on the advocacy work around this, and certainly not expecting any of these dollars in Q1 or most likely Q2 either. To be honest.
Any questions for Steve or anyone else on the team? Okay, I do have a question about the beta risk assessment. Trina, is that something that's self-imposed or is that something that is a requirement, or how did we?
We asked them to come out, they would do that.
Oh, very cool.
Yeah.
Thank you. That's it. Okay, cool. Please.
As I think about it, California Hospital Association regarding the Rural Health Transformation Program, what do they recommend we do? Do they have, and I know they're advocating, but or do they have developed any steps or guidelines for California districts of things they recommend we do to get our message further out there?
No, not yet. And I don't know the California Hospital Association members representing all hospitals, right? So
Yeah.
their recommendations will be very broad and blanketed to try to cover all hospitals. So for a hospital like ours, the Association of California Healthcare Districts will probably be most helpful, and their advocacy team. So we'll definitely lean on them and with our own contacts at HCI to try to, we have regular conversations with the healthcare finance folks in the state of California based on our distressed hospital loan. So that, I mean, the narrative that Julie spends, a month putting together every 3 months to get to the state, will be a big part of our application, I'm sure. We have no idea what the application process will be at this point or what they're going to ask or what that's going to look like. But as soon as we know, we'll get on it and be part of it.
Thank
you.
Okay, I will take public comment on this. I know it's just a receive and file report. No, we do want to give the opportunity for public comment. Anyone online wishing to speak on that report? Okay, seeing no raised hands. Anyone in person wishing to speak on that report? Okay, seeing none, I'll bring it back to, I'll close on the public comment and I'll move us on to item number 6. It's the Chief Financial Officer, December 2012, with the date financial performance update.
as Rosie's bringing that up, I will just say this is the kind of year-end recap for 2025. While we did not meet, ever to review the November financials, I'm going straight to December, and November data is, was sent out in the packet, and there are some slides in the appendix if you would like to review those. First slide, please. So as we knew, it was a really rough year for us, very tough, primarily with the lower volumes and the challenges that we had on the revenue side. And you can see that we finished the year almost $35 million behind in net revenue. And I'm going to go in a few slides in a little more detail on net revenue, but I'm going to really compare it to 2024 because I think that explains the story more than some of the programs that we had budgeted for that we didn't implement last year. On the expense side, you can see that we were about $9 million favorable to our budget. We definitely saved where we could, always looking for other opportunities to save. Very difficult to flex completely to the volumes that we had and maintain all the standards that were required to meet with staffing ratios and other work that needs to get done. And then you can see here that we did have some significant savings in our supplies. So that was an area where we are a little more agile in saving to budget, as well as with our new supply chain director being able to get more good processes in place, work on making sure that we're in the right tiers of contracts and that our contracts are solid. So we have some good savings there. Next slide. So wanted to drill down a little bit into the net revenue as compared to 24. So while I mentioned a $35 million unfavorable variance on the budget, you can see it's about $18 million when we compare year over year. And really, you know, volume did play a huge part in this. As you can see, we had $42 million less in inpatient gross revenue, which equates to just under $6 million in net revenue. And a lot of what contributed was having 80 fewer inpatient admissions, having a lower length of stay, so 1,300 less patient days. And then having, while we had roughly the same number of surgeries, we kind of had a different mix of surgeries. We had declines in podiatry and general surgery, which were both areas where we were missing physician presence for a good portion of the year. And we did luckily have some offsetting increases in GI and OB/GYN. But as you can imagine, sometimes the mix of surgeries also has an impact on the revenue that each surgery produces. On the outpatient side, you know, most of the hit actually came on the ED side. We were almost 19 million unfavorable or year over year less, which equates to about $2.3 million of less revenue. And it was primarily in the ED visits being down by almost 1,400 visits because we did have a slight increase in our non-emergency visits. And that, you know, increase probably would have been larger had we not gone the whole fourth quarter without an MRI machine. That certainly impacted us, as well as other times throughout the year where we had any sort of equipment or staffing challenges that might have precluded us from doing all the cases we might normally do. Really took a hit on the outpatient surgery side, 133 less outpatient surgeries, and largest declines there being in the general surgery again, and then ortho, which was also an area where we did not have a physician. And luckily, as Steve showed, that's an area where we've now replaced those two physicians, and they're in the kind of ramp up phase at this point. It was a strong year for deliveries. We actually had 52 more deliveries than 24 and finished the year with 816 deliveries. Another thing I wanted to mention is both on the inpatient and outpatient side, I kind of took a look at first half of 25 versus second half of 25, thinking that, we saw a lot of things coming after July 4th and after the signing of the budget bill. And so what I saw there, just in comparing those two time periods, was we really did see a decline in volumes. We saw 114 less admissions in the second half of the year than we had in the first half. And we saw 2,083 less visits, outpatient visits, in the second half of the year. And granted, some of those outpatient would be impacted by the MRI, lack of MRI. A couple other things outside of the and direct patient revenues, looking at the clinic of gross revenues, and again, both of those physicians, actually three of the physicians missing being coastal healthcare physicians, that impacted some of the clinic volume revenue. And so we were down almost $1 million of gross and roughly 235,000 of net. This was the year, you may remember, in about August, we took a one-time write-off of $1.8 million for bad debt. That was to get kind of more aligned with the industry standard of completely reserving accounts once they hit 365 days old. Previously, we were still reserving a small portion of accounts from 366 to 730 days. And while we were trying to be fairly conservative in what we were reserving, when we gathered it all up to write it off, it was $1.8 million. Our co-op and dish receipts year over year were down. A lot of this has to do with the timing. When these programs come out, they have dollars, and co-op 8 being a 2-year program had spread a certain amount of the dollars into 2024 and then the rest into 2025. And so when you looked at that, the receipts were actually down almost $6 million. And then last year was a year where we had some unusual non-cash, but revenue recognition that does come to our income statement. And these can be loan forgivenesses. These can just be, even when we made loan payments to Packard for the pledges that were used at the time that we bought the hospital out of bankruptcy. So not all of those sorts of activities repeated in 25, and that was another reason for the variances. Next slide. Also wanted to just talk a little bit about how the net revenue kind of shifted between the 2 years, just in the payer mix situation. We look at our major payers of Medicare, Medi-Cal, the managed plans, commercial plans, and self-pay. And so this was a year where length of stay was, slightly lower, but it equates to about 1,300 fewer patient days. And in some of our, like our commercial contracts, we get per diem rates for those patient days. So that's kind of a direct hit to reimbursement. You can see here that in our fee for service, Medicare and Medi-Cal, we had both a lower patient acuity and a lower length of stay. Patient acuity is a direct piece of the reimbursement methodology for how those accounts are paid, because they're paid based on a DRG. The managed Medicare admissions, those have been slightly going upwards, and so that's some good news. But we did see that those also had kind of a lower case mix and length of stay than the prior year. Our managed Medi-Cal volume, which is primarily our Alliance volume, pretty flat year over year, slightly lower case mix, but not real significant there. We did see more commercial admissions, which was the good news, but we saw a significantly lower length of stay. So again, going to the fact that most of those are paying on a per diem rate, you tend to this tends to be a little bit of an offsetting, comment when I say that the length of stay is lower. And then we did see lower, self-pay admissions, but the self-pay patients that we had were here for longer and they were a little bit sicker. Also 132 fewer observation cases and 127 fewer ED visits that resulted in an inpatient admission. Overall, when I look at the payer mix, and you'll see this better when I show that slide towards the end of my presentation that shows month over month payer mix, but kind of year over year, we did have some improvement in the inpatient payer mix with the commercial and managed Medicare volumes increasing. And we also, on the outpatient side, saw some improvement in the commercial and our Medicare. And that's good news. Next slide. So I'm going to look at expenses just a little bit differently, not to take you through quite as much detail. At the last board meeting, I introduced kind of the concepts of measuring on a year-over-year basis to a CMI adjusted discharge, because that allows us to kind of normalize the data both based on the patient acuity as well as our inpatient to outpatient mix. And since inpatient reimbursement is pretty different from outpatient reimbursement, with inpatient reimbursing, you know, at a higher percentage of charges than outpatient does, as we see more of our volume shifting to the outpatient side, looking at our data and comparing this way kind of helps us, again, normalize how we're spending our dollars. I did put the revenue, just to show you that almost $18 million worth of net revenue was about a 16% decrease on this CMI adjusted calculation. And where I think it is helpful is that you can see that overall our expenses declined by 1.1%. And as you look at the calculations and even all the things I say about our inabilities to flex to volume specifically, when you look at it from a case mix adjusted, you can see that we had a 2.2% salary increase year over year, which is right in line with what our contractual obligation salary increases are. So we are doing some work here to manage the labor expenses to the volume and to the acuity of our patients. Professional fees, as you might expect, grew the most because that is pretty much a fixed cost for us, regardless of the volume. And we also had some significant changes in our professional fee, our hospitalist group, our radiologist group, soon coming to our anesthesiologist group. So we had some increases there. We had some surgical on-call increases. So when you see it here and you kind of adjust it for the volume and the case mix, you see that that was a very significant increase for us. Next slide. I won't spend too much time on the month-to-date stats. They all were pretty unfavorable to what we had budgeted. And they were pretty mild, both on the inpatient and outpatient side to what we had experienced in 24. Probably the one bright spot here was that our inpatient surgical cases were up, and we had roughly the same number of robot-assisted cases. Next slide. I wanted to focus a little more on the outpatient side because this really ties back to the financials that I was just taking you to. And but this being more on the budget comparison versus the year-over-year comparison. And so our budget last year had been aggressive and also filled with some things that we thought when we were budgeting in the middle of 24, we thought we're going to be able to accomplish in 25. Things changed very much towards the end of 24. not only with the cyber attack, but then just as things didn't develop the way, we paused the pediatric program that was not anticipated, had been a significant part of our budget. The cath lab took longer to come online, and then we were not able to ramp that up as we had planned for. So some things that really, describe what looked like some pretty large misses on an actual to budget. And I'll just, remind you that going into the 26 budget, we took a much more conservative approach there, and actually in some cases, planned for flat or decreasing volume. Also, now we have a lot more headwinds that are kind of unknown when it comes to thinking about the volume. Next slide. I'll run through the graphs pretty quickly. The first one, this is just your acute admissions and patient days over the 12-month period with a length of stay at the bottom. It's pretty much what we've talked about month over month, not much more to say there. Next slide is deliveries. Like I said, that was kind of the bright spot this year with deliveries. Pretty good averages most months, and a couple of pretty high months in the 80s. The one thing that is a little bit hard to read at the bottom, but our NICU this year was pretty busy, and we averaged 9 and 10 patients in a lot of the months, and even had one month where we hit 20 admissions in the NICU. Next slide. Top graph here is the non-ER volume, and just kind of measuring the non-ER outpatient visits, and in the bars, and the blue being the ER outpatient visits. And then down below, kind of looking at this as the visits per day and the conversion rates. Overall, we converted about 6% of our ER visits to an admission. And we did see over the year, and especially in that last kind of part of the year, the ER visits per day decreasing, kind of finishing the year around 92 visits per day. Next slide. From surgical cases, nothing has really changed here to prior months, where we say, what's the top specialties that we do surgical cases in? They tend to be OBGYN, general surgery, and GI. So even with some of the loss of physicians for a period of the year, we still, general surgery still made kind of the top number of cases there. And then on the outpatient side, we have about 5 specialties that, tend to average at least around 10 cases a month, up to 40 cases, 50 cases a month. And robot assisted cases, we were down slightly year over year, but we finished the year fairly strong. Only had a couple of months, which happened to be September and November, but where things were really fairly low with the robot. Next slide. So here's the inpatient admissions, and I actually put a little green star up at the commercial admissions because we had a really nice commercial admission percentage in December of 20.7. That was a bright spot and a high spot for us. And for the rest of the month, obviously when you have that much commercial and you're doing this to add up to 100, it's got to fall out somewhere. So probably the major lower than normal would be in Medicare and the managed Medi-Cal. And the final slide is the outpatient payer mix. And like I pretty much say every month, this thing is very consistent and rarely changes much. It's a little percentage up or down here and there. And, this month commercial was down a little bit, Medicare was up a little bit, and everything else was pretty flat. That I will take any questions.
Any questions for Julie on this report before I open up for public comment?
Oh. I have a comment, Mel says. Comments are always gratitude, just like we're talking to finance committees. Gave a lot of additional detail and discussions, and I appreciate the ongoing candor and level of information you're providing and keep increasing that, so just thank you for that. And the question is in the ER, non-ER visits, and I probably should have asked yesterday. September in both non-ER and ER, we had a good spike in both those months. I mean, for September, both ER and non-ER, we had kind of an abnormal spike in the second half of the year. Any insights into why that was, and it's something we can talk about next month too? Just kind of curious about any insight
Yeah.
other than flu season or something.
Yeah, not off the top of my head. I can't think of that. Potentially could go back to look at some of our September data, or even September comments in our own drill down that I might not have shared here, but nothing is coming directly to mind.
Any other questions for Julie? Okay, I will open this up to public comment, before I come back for any closing comments from the board. Anyone wishing to speak on this item online? Okay, seeing no raised hands, anyone wishing to speak on this item in person? Seeing no raised hands, I'll bring it back to the board for any, final questions or comments, for Julie about this report. Okay, seeing none, Julie, thank you, as always, for the detailed report, for the real sober and transparent look at everything that's happening. Okay, I'll move on. We're gonna move on now to item number 7. And this is the organizational meeting and election of 2026. The Watsonville Community Hospital Board of Officers. And our contact here is Steve, and we have, looks like 4 motions in front of us. There's the first motion is to pass a motion electing the chair of the hospital board. The second is to pass a motion electing the vice chair of the hospital board. The third is to pass a motion electing the secretary of the hospital board, and 4 is to pass a motion electing the treasurer of the hospital board. And those directors elected to those positions will take office on January 29th, 2026. Steve, if you want to tee us up, and then I can add some color.
Yeah, you got it. Not much else to add other than a reminder that, our hospital bylaws state that officers shall be elected by the board annually as the first action taken at the first board meeting of the year in January. And this is our opportunity to do it in 2025. We've had Chair Nunez, Vice Chair Gallagher, Treasurer Pimentel, and Secretary Friel. And I believe there's been an ad hoc committee that's been put together to start to work on this.
Yeah. Director Pimentel, if you want to, as the chair of that committee, you want to give a quick report, and then we can make our recommendation to the board.
Not a lot to report. I think some of this is processing the loss of one of our board members, loss from framing. One of our board members transitioned to a new role in the hospital. So I don't have a lot to add. I think a recommendation would be to sustain ourselves for 2026, assuming everybody is comfortable in their roles, and to hopefully have a year where we can provide some continuing normalcy in our various roles.
Yeah. Any questions for either staff or for the ad hoc committee, which is myself and Director Pimentel, about that recommendation? Or... Okay, I do want to open up to public comment. Noelle, you want to?
I was just gonna suggest if you wanted to have a slate, you could do that instead of doing 4 motions.
Okay, thank you. Okay, anyone wishing to speak on, this item number 7, the election of the hospital board officers for 2026, online, please raise your hand. Okay, seeing none, anyone wishing to speak on this item in person? Okay, seeing no public comment, I'll close down the public comment, bring it back to the board for additional questions, conversation, deliberation, and then an appropriate motion. Yes. Just, I'll just very quickly just speak about, the past 2 years, as I think I made just a comment in terms of the workload, the past 2 years as the chair. Obviously, we made the recommendation from the ad hoc committee to stick with the current makeup of the 4 board officers, with the idea that the flexibility that provides, given all of the ongoing challenges with the hospital, and then some of the work that needs to be done at the ad hoc committee level with the external partnerships and so on and so forth. And so, yeah, so that's kind of how we came to that recommendation to stick with our current board officers, and the fact that there are several ongoing initiatives happening right now with the current makeup, especially with me serving as the board chair at the time, to continue to have that point person for those initiatives. Happy to have any additional conversation, but that's the recommendation for the board.
I'll just note my appreciation to our vice chair and chair. Sometimes in the normal course of my day job, I'll hear about one of you being somewhere, and I'm impressed with that availability, and sometimes in the normal course of my day job, I'll see one of you somewhere, and I'm impressed with that availability. And then at the board meetings, I hear all the other places you were at, and I feel like the 2 of you had a whole nother job, in addition to being a board member, so I'm grateful for your roles in that. Mayor, I continue to, Director Friel and I were just at a community presentation, one of the members came out and was very appreciative of Joe, yourself and your role in supporting our community. Just, you guys' names are out there. I know our bandwidth has been limited. So I just appreciate that you both have the capacity to be in places and be available and be accessible. And I'm hopeful that can remain into 2026.
I think I sent a text to another ad hoc committee that said, I said, haven't been fired yet, I think. It's been a lot of work, and I just want to put that into perspective, and also just thank Director Gallagher as well for making himself available. Just the amount of work that to put into an extremely important cause, I think, for our entire community. I appreciate the kind words, but and also kind of what we signed up for in 2022. Right. Okay, there's no other comments, then I will entertain an appropriate motion for this item.
I'd recommend that we vote as a slate to continue the 2025 roles in 2025 for 2026.
Second.
All right, thank you, Directors Pimentel and Friel. I'll take roll on this item. Director Friel,
Yes.
Director Gallagher,
Yes.
Director Pimentel.
Yes.
And Chair Newman.
Yes. Okay, that brings us to the end of the board meeting of the Watsonville Community Hospital Board of Directors.